Thank you for sitting down with us, Dr. Dickerson, and there's a lot of really interesting things happening in the field of phlebology, and I really just want to tell our audience, give them a brief about why you are a phlebologist, how you came about to becoming a phlebologist, the Lubbock Vein Specialist Group, and what is the offer and the difference of your center.
I started out pretty much doing general surgery, which is a little bit of everything. As my professor used to say, it's the surgery of the skin and its contents. Your average general surgeon, pretty much the common things we do are gallbladders, hernias, appendectomies, things like that. And that's what I started out doing. I've always had an interest in wound care and other things like that. And so that kind of led me, as time's gone by, towards venous diseases. And one of the big things that happened with that was about, let's see, I was in 2001, because it was right before September 11th. There was a cardiovascular surgeon here, an older guy, who decided to retire, and he was the only one in town who really took care of patients with vein problems. The rest of the cardiovascular surgeons weren't really interested in it, and traditionally that's been kind of where patients would be sent for that kind of problem. So at that time there was a doc here in town who asked me if I was interested in helping him out with some of his patients who had those problems, and he didn't know who to send them to anymore. And I said, sure, yeah, I'm interested in that. September 11th kind of got a little bit in the way, because I got sent away for about 10 months.
You got sent away, where'd you go?
San Antonio.
Gotcha.
Except for a short stint in Turkey, just a couple of weeks. I'm in the reserves, and what happened after September 11th, all the folks on active duty down in San Antonio got sent other places. Middle East, different places. And so the reservists traditionally are backfill. We fill in when they're gone. So they grabbed me and said, we need you to go and fill in for someone who's getting sent overseas. I'm like, yeah, sure. And I got lucky, I got sent to San Antonio, which is not too bad because it's not very far away from here, and I've been there before, so it was good. And during that time, while I was looking around at where I was going with my surgical career, realizing that there was this kind of gap in the coverage for venous diseases here in Lubbock, I started saying, well, this is something I've been interested in for a long time. Why don't I go in that direction? And that's about the same time that a lot of our minimally invasive or our non-invasive procedures came out, the closure procedure, radiofrequency ablation, and the endovenous laser therapy. And that was when I kind of discovered the American College of Phlebology. Since then, I came back, and I've been kind of building a vein practice since then. It eventually came to the point where I was interested in transitioning away from general surgery and into phlebology all the time, instead of doing some of each. And the medical group really wasn't interested in that, so I've gone out on my own, so I can do that.
Talk to us about Lubbock Vein Specialist. What's the difference?
Well, what I like to think our difference is from everyone else who offers these kinds of services is that we're more comprehensive. As my father, the engineer, would say, if the only tool in your toolbox is a hammer, everything looks like a nail. So if all you know how to do is one of the procedures, or maybe two of them, then it kind of limits your options and limits what you can offer patients. So what we try to offer is kind of a soup to nuts approach. Everything from cosmetics to venous ulcer care, and everything in between.
Let's talk about the treatments.
There are different types of treatments. There are what has been called in the past sclerotherapy, which most people think of, oh yeah, that's where you go to the dermatologist and they inject stuff in your legs and it hurts. And yeah, that still exists, the hypertonic saline. Everything has a fancy new name these days, and everyone wants to have an acronym for what they do, and now we call sclerotherapy endovenous chemical ablation, or EVCA. There's what's called radiofrequency ablation, which is microwaves, basically, generated by a box, like your microwave oven, that attaches to a catheter. The catheter's placed inside a vein, either by making an incision and placing it directly in the vein, or by using a needle and passing it through a needle, using an ultrasound to position it in the proper place and heating the vein from the inside to cause it to coagulate and disappear. There's also the laser techniques, the internal laser and an external laser. There's the endovenous laser treatment, EVLT, where, similar to the radiofrequency, the catheter is placed inside the vein, attached to a box, it generates a laser light, which then heats the vein from the inside and causes it to coagulate, clot off, close, and eventually disappear. Then there's external lasers of different wavelengths. Lasers are basically light, and this is invisible light. For smaller veins, the veins that can be seen on the surface can be treated by coagulating them with the laser light from the outside. There's also the traditional treatments of phlebectomy, which is a Latin term for vein removal, where veins are removed, and they always get upset with me when I say it this way, but basically what my grandmother used to use to make lace with, about a number 9 crochet hook, is what a vein hook looks like to me. And you make a very small incision, and you can put the hook through the incision and grab a hold of the vein and basically pull it out through the very small incision. You make a series of incisions over the vein and remove it that way. And for some veins, that's appropriate for that. Vein stripping still exists. There are different types of strippers that you can use. It's fairly rare nowadays that you find a vein that has to be stripped and is not appropriate for one of the other therapies.
You give back to your country, and I want to talk about that. And your experience being abroad, what you've learned from your experiences, and how you bring that now to the Lubbock Vein Specialists.
My reasons for being in the reserves are kind of, I guess they're kind of complicated. They're very personal. I consider myself a patriot, you know. I like to give something back. And if you look at the people who are out there doing the dirty work, they're kids. Most of them are 19. And somebody needs to be there to take care of them. And it's an easy way to give back. As far as world traveler, well, I wouldn't really say I've been everywhere, but I've been a bunch of different places, courtesy of Uncle Sam, which is kind of nice to have somebody else pay for it. But the biggest thing I learned going overseas and being deployed is that you can take a bunch of people who are very different, and in the end, they're really a lot the same. You know, whether we're from Texas or Oklahoma or Michigan or California or Iraq or Iran or Turkey or Bulgaria or Poland or Russia, you know, we're all pretty much basically the same. We all want the same types of things.
I can imagine that the experience that you gained out there allows you to, you know, come back to the States, not only, you know, project this, you know, knowledge-based information that you've gained, but also teach.
The really big thing that you can bring back is, you know, the good that's going on over there, because good news isn't news. The people who are happy, you know, the people that we take care of. And there's a lot of tragedy there too. I think everyone in this country should be forced to travel overseas and see how the other half lives, because it's my firm belief that the poorest person in this country is better off than 90% of the people in every other country in the world.
It's true.
Well, you see things in Iraq like mud huts with satellite dishes on the roof and new cars parked outside. You know, they don't have running water, but they got a satellite dish and cell phones and a car.
That's interesting.
And you meet people who don't know how old they are because they have no idea what year they were born, because no one keeps track of it because it's not important.
Yeah.
I'd love to go back there someday when people aren't shooting at each other.
Now let's talk about the center. You know, let's talk about the experience and what can someone expect, first impressions.
First impression. Well, hopefully their first impression is that we're friendly and approachable. That's what I would hope, because that's the way we try to approach everyone. That it's a comfortable experience, it's a personalized experience, and that you get all your questions answered. It's not like the experience that you might have, you know, someplace else where you come in and you talk to a couple of people, the doctor walks in and says, "This is what you need," and 2 minutes later they walk out, you know.
What type of patients mostly come to your center?
We'll see people who are coming in because they have cosmetic reasons. They have some spider veins that they don't like the way they look and they'd like them gone so they can go on a cruise somewhere and look really great in that nice bikini they just bought. All the way to the people who have ulcers on their legs that haven't healed for years and are looking for, you know, a chance to have them get better, and everything in between.
minimally invasive, explain to us what this means and what can, patients expect. So, I mean, words like vein stripping, and I think most of the public is not really educated to know where technology's at.
I'm sure a lot of people, yes, they probably remember the old-fashioned vein stripping their grandmother or their mom or somebody had, where they come home from the hospital with their legs all wrapped up in these huge bandages and they're not allowed to walk around, and there are these ugly scars and bruises all over the place. That was the procedure that we had up until about 8 years ago. We used to always do operations through big holes. See somebody who had their gallbladder taken out 20 years ago, they've got an incision that goes from here to here, because the surgeon had to put their hands inside in order to take the gallbladder out. Well, now people, if they've had their gallbladder out, have an incision, like 3 little ones that are like that big, because we don't have to put our hands inside anymore, we just have to put the instruments inside so we can make smaller holes. Same type of thing has happened with vein surgery. We can make very small incisions or no incisions at all and treat the veins with either the radiofrequency or the laser. Basically, it's a matter of placing a fiber or a catheter of some sort inside a vein, usually using a needle, like having your blood drawn. Needle's placed in the vein, and then the catheter is threaded through the needle, and an ultrasound machine is used to guide it into its proper place. It's a laser, it's attached to a box that generates a laser light, and it heats up the inside of the vein, and as you pull the fiber out, the vein plots off, closes, and shrinks down, and eventually disappears.
Can one expect to walk the next day?
Oh yeah, within a couple of hours. We want people to get up and walk afterwards. That's the best thing for them after surgery. Any type of surgery, especially vein surgery.
How do you take care of this procedure?
Before one of my patients has the procedure, we talk about this, and basically I recommend that they do a 20-minute walk once a day, 5 days a week, if they can. Some people can't manage that. My patients are elderly, or you have other physical problems that keep you from doing that, then we have other options. But your average patient, a 20-minute walk, 20 minutes worth of walking during a day. It doesn't have to all be at the same time after the procedure is recommended. Most people return to most of their usual activities within a couple of days. Very few of my patients, I give them all a prescription for pain medication in case they need it. Most of them tell me they don't ever take any of it. Most of them will take a little non-steroidal like Motrin, ibuprofen, aspirin, something like that afterwards, and they're fine. A lot of them go back to work within a week, depending on what they do for a living and their situation. But most people are pretty much back to all their usual activities, unless you're really into hot tubs, within a week.
It's an easy process. Yeah. Let's talk about your staff, the people that work with you.
Where to start? Well, Sherry, she's been with me for quite a while, a number of years, and she's a gem. She's great at explaining things to people and answering questions and giving them a non-doctor's point of view on what we do, and a non-clinician's point of view, since she's not a clinician. And she's a whiz at getting the insurance companies to talk to her on the phone, which is something that's really hard to do.
Really important.
And Anita's been with me less time. She's very friendly, very outgoing, loves to talk to people. She's learning a lot about how we work, and is going to be a great asset.
What are your ideas and what are your goals?
There's a couple of things that I'd really like to see. I'd really like to see more cooperation between the different parts of our medical community. I had a conversation with someone from the dean's office at the medical school there a little while ago. And in a lot of towns where there are universities, there's kind of a town-gown separation. And in Lubbock, it's really not town-gown. It's more the places that we work, because we spend the majority of our time in one hospital or institution than we do in the other because of the nature of our work. And so this kind of divide has grown up between these two institutions over the last, well, how long has tech been around? 40 years. And it's come to a point where, with the way medicine is going, is that we need to all be one community. We all need to work together. And now we find that when we try and reach across that gap, that there is a gap there, and there is a division between us that we have to bridge somehow. And that's something I'd like to see some of those walls come down.
Yeah, at the end of the day, it's all about the patient. You know, why not?
There's nothing like teaching a bunch of medical students to keep you on your toes. Part of the Hippocratic Oath is to teach, and we need to give back in that way.
Where's the Lubbock vein specialist going to be in the next 5 years?
We'll continue to grow, that we will be able to continue to offer all the new emerging technologies that come along to all of our patients, and that we'll be able to expand into whatever niche is needed to be able to keep offering people, comprehensive care for these types of problems.